Hey, it's Justin Harvey. Thanks for tuning into the Anesthesia and Pain Management Success podcast. With APM Success, we take a close look at important topics pertaining to business, practice management, personal finance, and careers for anesthesiologists and pain management physicians. We work hard to take your critical questions straight to the experts. Thanks for listening. Hello and welcome to another episode of APM Success. I'm very excited to be joined today by Dr. Tim Deer. Dr. Deer is the president and CEO of the Spine and Nerve Center of the Virginias, a proud mountaineer, and is the chairman and founder of the American Society of Pain and Neuroscience, among many other distinctions. Dr. Deer, welcome to the show.
Justin, thanks for having me. It's a real honor to be here with you again. It's been a while,
so I look forward to
the conversation.
Yeah, so I still have a little bit of tan from Miami. I don't know about you. How did the conference go this year at Aspen?
You know, it was as every year I get more and more encouraged by the field, and this year's meeting was in my career. And I've been involved in many societies. I've been president of societies. I've been on the board of many societies. This was probably the best society meeting I've ever been to, and certainly. We had over 3,000, like 3,100 people registered for the meeting. We had another 1,000 or so there for off-site meetings like advisory board. So we think we had over 4,000 people there. But even more importantly, the diversity of who was there. We had just a lot of young people. We had over 1,200 people either in training or in their first 5 years after training. We had a great diversity in gender and different specialties. And race. We had ortho spine there as well, neurosurgery, radiology, and pain. And we also had a lot of industry there. And, I think, sometimes you hear people that for anything product development-wise, research-wise, study-wise. So I think to have that collaboration in a very transparent fashion was quite good. Outside of the CME, which was separate from industry, I think the other things that went on there to really build collaboration among physicians and APPs and scientists with industry was quite good as well. So the whole thing to me was goes back to a compliment to those who planned the meeting, which wasn't me. I recused myself from everything about the meeting. So Kaz Amardelfon, David Lee, Dawood Saad, and others really did a fantastic job. Melissa Murphy did the Horizons segment. So I think all that was so well done, and it just goes to show the talented people in the field. So to me, it was fantastic. But more than just enjoying this year's meeting, it encouraged me for the future.
Yeah, so speaking of the future, I know that one of the things that Aspen has done, and I've participated in this a little bit with some of the Poster to Podium program, but like creating a sort of a launch pad for new in practice attendings to be able to develop the connections, the research resources, mentorship, and those kinds of things. So how has what's the current offering, I guess, in Aspen for new in practice physicians, and what are you most excited about there?
Yeah, I think to me, when I created Aspen with Dawood Saad, one of the things I wanted to do was create a home for young people to be able to get involved, because so many societies I was in before, you had to serve your time, if you will, for years trying to get on some committee or some task force. So we've got a lot of things going on that's been very helpful to young people, I think. Number one, we've got the Poster to Podium program Erica Peterson started, which is fantastic. We have a Young Innovators section that's run by 4 young people that do a fantastic job there. And they really have created teams of people that write papers together. We have a senior person like myself. I have an idea, and I can then team with 6 or 7 young people to get, and that helps, number one, the field. Number two, it helps build the resume for people to get, promotions, jobs. And then we have Neil Mehta now with a new idea, which he's out of Cornell. You may know Dr. Mehta, a fantastic guy. He's going to create a promotion program where people that are in academics can come in, and we can work together to help, important publications to help build the chance for promotion in academics. That'll be a brand new program we're launching this year. We have the Maggie Gerges down in Oshner is running a program that will look at centers of excellence, whether you be a solo practitioner or a big academic center, the criteria he creates. So all these things I think are going to really help those coming up in the world. Lastly, the MIS certification program will be able to have young people get mentored for minimally invasive spine procedures and techniques to get a certification that you've completed the appropriate work in your practice to show you have the knowledge to really be able to effectively go out and do the right job with MIS procedures, which are going to continue to evolve, and several hundred, I'm sure, in the pipeline right now as we speak.
Let's talk more about that, because one of the things that has been said in the pain management realm of late is that maybe this is a 2-year fellowship and not one, because look at all the multiplying procedures and the limited time clinically. Like, there's only so much you can shoehorn into a 1-year fellowship. And it seems like this is one potential answer to that, with specific therapies and being able to get additional training. So how is that unfolding?
Well, so, Tim Lubenow and Daniel Pack and others have done a great job with our fellows program at Aspen. But I think that those who think there's going to be a 2-year fellowship are fooling themselves. No one wants to do a 2-year fellowship. And 2 years of bad fellowship doesn't make it a good fellowship. So you still have the same problem you have today, and that there's some fellowships that just aren't very good. Unfortunately, you don't learn much there. So I think there are some really good fellowships as well. But so I think this is a good bridge for that. And that's one of the reasons we developed this program. So let's say you're in a fellowship at a great place where you learn a lot of basics, but you don't get to do much in the way of new things because of politics or turf battles, or wherever it may be at your place. We have created a program where you can come out of your fellowship, get the proper training. And again, industry trains a lot of people, which I think is fantastic. But problem is there's no mentoring after the training. So if you're going to do an industry-based program, for example, you go back home, you get a mentor. Let's say Angel Boev, who's a neurosurgeon in our MIS program. He's one of the leaders of the program. You get Ashley Bailey Clausen. You get somebody like that, and you start keeping case logs, taking X-rays and MRIs, and as you go through those cases, you have a mentor to go over the case with you. Well, here's why your outcome was great. You picked the right patient. Here's why you didn't have a good outcome, because you picked the wrong patient. So you get mentored as you go along, and then at the end of that, so we're gonna have that program. There'll be a didactic session every month. Dave Dickerson's heading up that program, and then you'll go visit your mentor once during that year and watch your mentor do cases that you're already doing as well. And then you'll come to Miami next year, and you'll take a written exam. Toga Salva up at Russia is designing that program, and many people listening probably ask the right questions for that. And then you'll also take a practical hands-on cadaver exam, where Pankaj Mehta will lead that program. And you'll have to pass both segments of that to get the certification. Now that's different than credentialing. You still have to go back to your facility and do the proper work for credentialing, but it will help you, I think, with understanding the proper patient selection, proper technique, and the proper post-operative management. I think it's going to elevate the space, and I think a lot of people will see it as eventually as a critical part that bridges that problem of the 2-year fellowship. But the 2-year fellowship will never happen. I know that because I've talked to a lot of fellows, and they all say, man, I don't even want to do 1 year, because a lot of anesthesiologists now have jobs out in the space. We have a lot of PM&R people, neurology, emergency medicine coming into those slots, and they're going to do a good job. But I think if you think there's going to be a 2-year fellowship, you're fooling yourself. That's what I've told some of my colleagues who've written those editorials.
I'm curious, you were listing some of the specialties when you're talking about the attendees at the conference, and what we have seen in anesthesia and the anesthesia shortage, and we can't make enough MDs, CRNAs to meet the need of that, the bolus of boomers that are hitting that like high need time procedurally. And so there has been less people entering pain from anesthesiology, in part because of the compensation commanded by the specialty of anesthesia. So how have you sort of observed that, and how do you think the field may evolve because of the integration of, emergency, for example, or other specialties that are contributing more participants?
Yeah, I think it was Mark Twain who said the rumors of my death were greatly exaggerated. So I think people think that pain is going away.
That's not what I was implying by any stretch, but
it's not true. I think I mentored, I think in the last few years, probably 20 physiatrists. I'm an anesthesiologist by training, but I have a lot of great friends in physiatry. But I've mentored a lot of residents who are at programs sometimes that aren't real interventional, and they want to get an interventional fellowship. So I've helped them, and I think all of them now have matched in a fellowship. 5 years ago, that wouldn't have happened because, a lot of those fellowships wanted anesthesia-based people. And what I'm finding is the physiatry-based people are very well trained, very smart. I've had a few neurologists visit me in residency that wanted to go into pain and got fellowships. And recently I had 2 emergency medicine physicians who did the same and got fellowships. Chris Gilligan set the bar there early on. He was an emergency medicine physician. He went and trained with Jim Rathmell at Harvard. So, we know that can be done well. So I think that will be fine. And the reason we'll be fine is because of our community. We're going to mentor these people. And between the fellowship directors who will do a great job in most places and our community for post-fellowship, I think we're going to have really elevation of the field, not decline. So I feel really bullish and optimistic about the field. And I think everything's cyclical too, Justin. When I came out of training, there were no anesthesia jobs. So thank God I'd done my pain fellowship. But then 5 years later, there were a ton of anesthesia jobs, right? And there was a need. And then there were no anesthesia jobs. And so this is all cyclical. I think the real difference is now, like, from my practice, for example, so many people want outpatient surgery. They don't want to go in the hospital. And so that means we need more anesthesiologists and anesthesiologists in surgery centers and offices and things like that, which before most things were done in a hospital. So the demand for anesthesia is going like that because we're doing more and more simple, low risk outpatient procedures, but we still need people to be there to fill the need of the anesthesia.
What other therapies are you working on right now, or part of the research, or part of the laying the groundwork that you're most excited about?
I'm excited about so many things. And so I'll break it down to three kind of divisions of things I'm excited about, and then we can talk in more detail. So number one, I'm excited about modification of things that make something that's already going on better. And I'll give you an example. I'm working on something called G6, which is the new next version of Minuteman, which will be very, very small compared to current therapies. Working on making Zip Aurora smaller than it is currently and make it less invasive. Working on new SI joint methods that are similar to current methods, but more efficacious potentially, and also further minimally make the procedure less invasive. So all those things are modifications of existing things. Working on new DRG leads very shortly, working on new ways to anchor devices and new hardware for some of the companies that do closed loop. So there's just so many things on that list of modification of making things better than they are. And that's what we've been doing for 20 years. We've been doing that. I think two is a category of things that are new. Things like intradiscal stimulation, things like annular tear repair, whether it be with a new agent or a new technique. Things like silicone implants of a disc, things we're looking at there. So there's things that have never been really thought of before that may be really helpful. I think that to me is going to be really a very evolving. The intradiscal therapies and annular therapies, very evolving. And some of those could be just phenomenal for making outcomes better. Last category is things we need more research on to support patient reimbursement. And the most excitement I have there is something called the RESTORE study for Vibex, which is an intradiscal human allograft. And it's already approved by several Medicare carriers, but we want to further strengthen the level 1 data. So we're doing a multi-center 450 patient study, randomized sham study. So I think that's like the highest level of science, looking at really both pain-based people like myself, interventional spine. We have some interventional radiologists involved in the study. We have Dr. Pierce Nunley, who's the ex officio advisor to Aspen as one of the world's most prominent ortho spine surgeons involved. So we're looking at like level 1 evidence like that. I think it's gonna be fantastic. And then the last thing I'll mention in that realm, we're doing the first in human new peripheral nerve simulator that I think can be a new, next generation of peripheral nerve simulation. Nirvanic with some engineers out of UCLA. And I think, again, we're looking at, can we make something that's so different than what's currently available that it changes the way we think? And that will pan out one way or the other based on human experiences and real world data. So those are some of the categories. That was a lot to throw at you, but those are some of the categories right now that I'm working on. And I think I silo those into different areas because they require different thought processes, different engineering, different data analysis, and different levels of funding for things like research and development.
One of the categories, the third, was need more research to support reimbursement. So obviously reimbursement, it's no secret to anybody out there who is involved in billing or running a private practice that the RVU for the physician is sort of, it's the shrinking iceberg effect. I kind of like to describe it as. And so talk to me a little bit about your interactions with, or even your personal experience with your practice in West Virginia, with the reimbursement dynamic and some of the work you're trying to do to create data to have the dialogue with payers to say, hey, listen, pay up because we're adding value, we're shortening recovery times, we're using technologies or therapies to create better outcomes.
No, great question, Justin. I think that's fantastic. I'll tell you two things that I think that really excite me, and then I'll tell you some things about my practice. So number one, we have a request for proposal right now with Aspen for a registry of our members. And I think if we get a registry for our members, and we will pick a partner to do that with, we'll be getting hopefully some funding grants from different people in the field who want to have the same knowledge we do about what does work and what doesn't work. The beauty of a registry is we'll be able to tell you, based on this patient, don't do that procedure. So it's not just who does well, it will also tell us who fails. And I think that's really valuable. So I plan to work with Jason Pope and others to publish that data once it's available. We'll announce our partner for the registry by the end of the year, and we'll start the registry in January. I think it's gonna be fantastic. That'll help us all. Number two, I'm working on some big data right now. I'm working with some of the strategics on big data. And I just presented big data 5 years showing that spinal cord stimulation did reduce the opioid use by dramatically to a level below that 50 morphine equivalents that CDC found the level where death goes up. So we talked that we do these things, but we actually showed in big data. And not just, not some company biased data. This was Medicare data banks, right? And payer data banks. So we're showing that. I'm planning to do a lot of publications in the next 24 months on big data from Medicare data banks, as well as public insurance data banks. And no one can fudge that data. No one can influence the data. The data is the data. To me, that would be one of our saviors going forward. And then I'll go to my practice. We're really having pretty good success with getting approval for most of the minimally invasive things we do. But I tend to stay on label and follow the studies. So if we have a indication that Medicare approves, we'll actually take the patient who has those indications and we'll request it based on that. And we tend to take the approval language from the payer and put that into our request with the documentation what the patient has. So I think that goes back to really my staff doing a really good job of documentation, but also matching the criteria. And if you go off label and do things that aren't really indicated, it's not surprising you're going to struggle, right? Now, occasionally there's a procedure that should be approved based on all that, and they still deny it. And they say it's experimental when it's FDA approved and it's CMS approved, and there's a CPT code. That's criminal of the insurer to do that. I think that unless the federal government gets involved and makes them follow, for example, the Medicare Advantage plans or disadvantage plans, when they don't follow Medicare guides, they're supposed to, as you know. I don't know why the federal government doesn't step in and say you have to help these patients, but they call things experimental. So other than that group, we're having good success in my practice. So you're really having some of the best years we've had, but I think it's because we do have great documentation. Mm-hmm. And at the end of the day, that's what it's going to come down to, right? To get approval for anything. But that experimental category drives me absolutely crazy.
One of the things you just mentioned, I'm curious about the process. You mentioned using the Medicare data to be able to, for example, document the decreased opioid use by a cohort of spinal cord stimulator patients. Can you just kind of granularly explain how that process works of getting that data, putting together that study, coming to that conclusion? Because I don't really understand how you would access that data and how that works.
Yeah, so actually I presented that, our first abstract at Aspen. It was chosen, and again, I recused myself. I had no voting here, but it got chosen as one of the best abstracts. I presented that orally. And Nandan Ladd, actually neurosurgeon from Duke, was on that study with me. He presented it on Sunday, actually, that date. I presented that during one of the lunch meetings. But so example would be, there's two different examples. So I'm working with a PhD scientist from one of the minimally invasive spine companies, and we got all the data from Medicare data banks, and we query different diagnoses codes to see which is more common in a pain practice. And we took some large practices and we looked at all the diagnosis codes. Is it more common to get a patient who comes in with MIS diagnosis, would be appropriate based on labeling for MIS? Or is it more common to get a neuromodulation candidate come into your practice who would meet the criteria for that? And we haven't published this data yet, but 10-1, there were more people coming in who had MIS diagnoses to the pain practice. So number one, we're seeing a trend in people getting sent to pain practices for minimally invasive spine, more so than anything else. And I think that is interesting. And that's based on data on diagnosis code only. So that's just an example of what you can look at. So we just want to publish that to show everyone that I think MIS is largely the future for a lot of things we're doing, although neuromodulation remains important. But Alex Bennison's a PhD at Abbott. He and I partnered together to get data bank queries. And again, you need your diagnosis code, the procedure code, the CPT. And you take all those codes together, and then you can go in there in the data bank and get a lot of data. Then you need someone who's really smarter than me. You need a good PhD team to go through and analyze it. And then you need great statisticians. And then you can go back and look at what the data shows. And I think, we published, I think 110,000 patients with stimulators a few years ago, looking at rechargeable versus non-rechargeable. You can Google that on PubMed. You know, you go on the PubMed and find that article. And that was the first example. And then we take 110,000 people and we had all the criteria to make sure they were proper. And you say, okay, this group didn't have a rechargeable battery, so now they come to here. Okay, that group, didn't have whatever it may be, the right diagnosis code, comes to here. So then you whittle that down to 20 or 30,000 people. Still, compared to most studies, which have 200 people or less, that's a huge number, right? And then you say, okay, how was their utilization of more surgery? How was their utilization of more drugs? How many times were they admitted to the hospital? So you can really quickly build a story, good or bad, of what works or doesn't work. And then we can go to a United Healthcare or Aetna, and we can say, here is a big set of data that shows if you approve this procedure in this group of people, whatever it may be, the outcome's great. But I think, again, to be honest and fair to everyone, when we see trends that something doesn't work, we should do the same. We should say, if you do this procedure in this group of people, they will fail. And until we can do that, I think we're going to be a little bit, really untruthful, because we need to look at both groups. And that's my interest. I want to see who does well and who doesn't do well. And can we predict that in advance? I think we can predict it in advance.
And then when you have that research in hand and you approach one of the insurers and you say, here's what we found, what has your experience of that dialogue been?
Well, it's interesting you asked that question. So Nalu, Curonic, some of the peripheral nerve stimulator companies have been doing a really good job talking to industry recently, to insurance. And, Nalu created a team of people recently that they invited me to be part of, to talk to the insurers directly with data in hand. And we've had some success. There's been some new insurers coming on board. Mainstay, again, data-driven, just got Anthem, Blue Cross on board with their data, but it usually takes 2 RCTs or more to get that. And Jason Hannon did a fantastic job getting that RCT data. So that's a good example of that. I think Hemant Kalea, our regulatory vice president at Aspen, he has really done a fantastic job talking to insurers and being an advocate. But I think it's a combination of data, studies, and then talking to insurers about what it could mean to them as far as offering access to patients. And patient satisfaction should count for something to insurers. I'm not sure if it does sometimes, but I think it should count. So it's a combination. It takes truly a group of people in different realms. But at the end of the day, I think insurance is often we can convince them, but it takes a lot of data. And DRG, I'll give you an example. I remember Alan Burton and I talked to many insurance companies to get DRG approved based on, we had great data. And one by one, they saw the same thing among their insured lives, and they started to prove it more and more. And I think, so it's good data, and then the insurance companies have to see the same thing in their own set of patients that we're seeing in the data, right? So if the data is great and it's not reproducible by anybody else, it doesn't matter. It has to be good data, good studies, but then the real world has to match. And I know the insurances track that carefully as they go forward. And so they may disallow a procedure later that we got approval for because the outcomes aren't good once it's in the bigger population. That tells me we have to do a better job of patient selection and make sure that we do things that match the study, because that's who does well. If it doesn't match the study, you're going to fail. So that's a long answer to that question, but I don't think it's a very quick answer to that question.
Yeah, not a lot of short answers when it comes to the payer dynamics. It's always
absolutely
takes a little 100%. Bit to unpack. So you are someone across whose desk a lot of data is constantly passing. I'm curious if you have anything coming to mind in maybe recent years where something you've changed your mind about or meaningfully amended an opinion based on either new data or just even experientially, like something you've changed your perspective on.
No, I think there's a lot of things, I mean, I'll give you a few because I think there's a lot. I change my mind when I see evidence that, my friends have experiences. Originally, I think I didn't think multifocal stimulation was going to work. I was skeptical of that. Now I'm seeing more and more data, reproducible data. So I think it's obviously does have a good potential to be a great long-term therapy for people. I really didn't think SPR could work. A 60-day trial sounded ridiculous to me. And we've used it quite a bit now, published on it quite a bit. So I saw that change my mind. I was pessimistic about BVN initially. Now we do BVN. I did one today. We do BVN frequently, but they have to have the right findings on MRI. So I think I didn't think we could lower the energy requirements of burst in SCS, and we did. And I was with Dirk Ritter in Nashville 2 nights ago lecturing, and Dirk and I did a lot of research together. But we did studies to show we could lower it and lower it and lower it, so the batteries got smaller and smaller and less recharging. I wasn't sure that paresthesia-based closed loop would be helpful. And we've been involved in many studies on that now, and we've seen fantastic results. We have something called the Ultra study that Marcy Karsh presented at Aspen here with our real world data that's patterned after evoke, but it's in a real world fashion. So, I mean, that's just a list of a few things. The last thing I'll mention is I really thought that new techniques would be no better than Vertiflex initially, because, I was the first non-surgeon to do Vertiflex many years ago, and we were in the study with the spine surgeons. But we really have found that the new methods of really posterior lateral arthrodesis or open arthrodesis are having great results. And so I was pretty skeptical of that initially. And we've been really proven to be wrong. And then I thought the posterior method was the only thing we should do for SI fusion. And now I still do the posterior method, but now we've had great results laterally and laterally oblique. It just takes the proper training, patient selection, review of films beforehand. So all those things are changes in my mind in the last, I'd say 5 years. And I hope 5 years from now that if I'm still practicing, you're still podcasting, we have another discussion, and I'll talk about 5 more things that, I didn't think were going to work that pleasantly surprised me. But I think that goes back to the quality of our field. We're getting great doctors doing great work, and we're seeing improvements in outcome.
Something you mentioned in our email exchange prior to this conversation was new perspectives related to collaboration, and then a trip to Mexico to sort of give corners and edges to this idea. Tell us a little bit about that.
Yeah, so Spine by the Sea, meeting run by Frank Phillips from Rush, wonderful ortho spine surgeon, and several of his colleagues who I had the chance to meet, all of whom are just fantastic leaders. In the past, I think there'd only been one other interventionalist ever there, Doug Peel, who's on our board, one of the interventional radiologists. And although Doug is amazing, I guess there was some controversy there. And so I went and gave a talk there. I was invited to be the first interventional anesthesiologist I guess they've ever had at that meeting with about 400 ortho spine surgeons. And I talked about all the things we do. And, surprisingly, my reception was quite warm. And I think of all the people there, I've made a lot of good friends. We have about 10 of those really prominent ortho spine surgeons coming to Aspen next July in Miami. I think we're going to have some of the world leaders there from ortho spine. We already have some there to begin with, and now we're adding these new people. Pierce Dunley was there, a lot of other folks. And I think what happened there was we really understood each other, that really we see it as a continuum. We see it, if you really need a big surgery, you should have it. But sometimes we can do smaller things and you can do just as well. Or maybe you're too sick or too old or too fragile to have a big surgery, and maybe that surgeon will send you to us. And when we had that discussion, they all agreed with that. And we just had, these were all really thoughtful people. I did have one little discussion with one doctor who will remain nameless, and he brought up the old thing that I heard in med school from the cardiologists when they started doing stents. You shouldn't do any of these things. You can't handle your own complications. And I pointed out to him in a very, well, I thought Jason, I thought it was kind of a nice way. I pointed out that I see people all the time after spine surgery have severe pain in their leg, but scar tissue forms, complication of the surgery, it doesn't mean you did a bad job, but I end up seeing those people for spinal cord stimulation, and he was an ortho spine surgeon who doesn't do that. So he couldn't treat his own complication. And if you get an infection in your disc or your bone, guess who treats an infectious disease, right? You can't treat your own complications. So I pointed out to him about 6 examples of things he couldn't treat that he caused. And actually, at the end of that conversation, he gave me his email address and asked if we could work together on some projects. So it turned out to be favorable, but sometimes, you have to reset the discussion, because it is true that none of us can treat everything. We need collaboration. So I think it was a really good first step in really building that community. And I think the good surgeons I met there have the same goal I have, and that's to do the best job we can. And they don't want to be more interventional than they have to be either. I mean, they get some terribly hard cases that I can't do, and I would never want to do. But they also get some people that we can do something smaller for, and they're going to do great. So I think once that discussion's made, there'll be outliers. There'll be people, recently there was somebody running a group in the Southern United States who runs a venture capital-based pain group, and they're trying to do everything without the surgeons. And I think that's probably not going to be a good idea. That's probably money driven, and I think that's a mistake. And sometimes you get some great venture capital owned people, and you got some that are kind of, money driven. And then you get some surgeons who want to do something big in everybody. So both those outliers will fall out, I do believe. And I think people that are really thoughtful, mindful, will come closer together, and we'll have a good relationship. And, I think that involves respect. Also, many times I have patients see our surgeons and get their opinion before I do anything, and that also builds that rapport because we can discuss options. So I give it a 10 out of 10, that meeting in Cabo. Certainly an honor to be there with the folks. I learned a lot there. They taught me a lot about mechanics, things I didn't know. So I think for me, it was a great learning experience.
Yeah, I've heard it said that the spine is sort of an interesting, because of the less and less invasive therapies available, and because of for example, the advanced trainings that a group like Aspen is providing to physicians, that pain docs can do more and more. That historically there has been some gatekeeping by the surgeon community. And there's still a lot. I mean, I talk to clients of mine, and I'm sure you see this, like, yeah, I can join this ortho group as a pain doc, but like they said, I can't do this whole list of things that either they won't do at all, or they're just not going to let me do because I'm a second class citizen, to be honest, is sort of my observation of what's going on there, because I didn't do a surgical residency. How do you observe the dynamics of that dialogue evolving?
Well, two things are changing, and I think they're both going to really shape what you just asked me. One is, we're becoming the gatekeeper in many communities. So in many communities, I think COVID was the changing point. People don't want to go in the hospital. They don't want a big surgery. They don't want a fusion. They don't want, they hear about their friends having this issue when they were during COVID and they got sick after surgery. And so our number of referrals went way up during and after COVID. And I think more and more interventional pain people are becoming the gatekeeper, because the referrals come to us. Remember, if you're a surgeon, if you have to see 30 people to get one surgery, that isn't very good use of your time, right? So some surgeons like this process where we're the gatekeeper, because they'd rather get 3 or 4 good referrals from me than get 25 from a family doctor they can't help. So I think in some ways that's really good for the surgeon too. Amount of spending in interventional spine space versus amount of spending in big spine surgery space. It used to be, here was spine surgery, here was interventional pain. Now, the amount of investment right now in early products in the spine and interventional spine is here, and big spine surgery is here. So we're seeing a shift where the funding of new techniques are coming towards us. And I think that would be, that means the war is over. There'll be more battles along the way, but the war among which is the best way to go, as far as most patients, is over. MIS is going to win. Interventional spine and spine surgeons who want to do less invasive things will come together and do a great job, figure out who's the best. But I think it's, so what that situation you just described, Jason, I would say, there's all kind of issues there, but if you're properly trained in credentials and someone tries to stop you, then you probably have a lot of recourses so you can use for that. And again, I'm not a lawyer, but I certainly have some knowledge about those recourses. So if anyone wants to talk to me about that offline, I'm happy to speak with them. But you can get through that. But I think the best thing to do is educate those who can be educated. And some people just can't educate men, and so then you just have to crush those people in some way, shape, or form. But that's a talk for another day.
Yeah. As we're wrapping things up here, and as you look ahead to the next few years and where the specialty is headed, what are you most excited about?
I'm most excited about young people and what they're learning and how good they're getting. And, we have so many residents in Miami this year, anesthesia, physiatry, radiology, emergency medicine residents there, and I think that we're going to see the skill levels of people elevate to the point where we're going to be very, very proud of outcomes. So I think I'm most excited about the youth of our field and where it's going. Secondly, I'm most excited about, I think MIS is still in the very beginning. I think new generations of things. I think the disc is an area where we failed in the past, treat the disc. We're going to have great success in the disc this year, over the next 2 years. I really believe that. Neuromodulation, has kind of become less common, but I think we're going to see better and better outcomes there. And so I think we'll get new indications like diabetic peripheral neuropathy. We're having great outcomes with neuromodulation there, for example. We'll see more indications. So there's a lot to be excited about. It's a great field. Aspen wants to be the home of, young people, older people, mentors, mentees. But the other thing I'm really excited about this year at Aspen, we had more venture capitals and bankers I've ever seen. And I met with a lot of those folks, and they all want to invest in minimally invasive, efficacious, safer things. and product development requires investment. So I think when you see the investment community come, when you see companies like Stryker divest from the spine world and go into MIS, like the mild procedure, which I've been involved with a lot of those studies, as you know, I think that tells you the future is so bright. And so I think the next step is to figure out how we can invest in early companies before they ever have a product available for patients, so we can help innovate early and build really better outcomes as they go forward. To me, that's very exciting.
Excellent. We'll wrap it up there, Dr. Deere. Thank you very much for your time today and lending your expertise to the anesthesia and pain management success community.
Well, I always enjoy your podcast. You do such a wonderful job. I listen to it frequently, and I think you're probably one of the best interviewers in the space. Thank you so much for having me today, and look forward to having you at Aspen in Miami next July. And for many of you, check our website. We have ISPN, October 8th through the 11th in London, and hope some of you can join us there as well.
If you liked what you heard this week, head on over to apmsuccess.com, where you can find more content and free resources to help you build a successful career in anesthesia and pain management. If you wanted to leave a review in iTunes, I'd also really appreciate it. Thanks for using some of your valuable time to join me today on APM Success.